All right. Hi, everybody. Welcome to the COVID-19 Task Force webinar today. And we're going to talk about handling the epidemic in the congregate settings. As you know, we're all being advised to stay at home, minimize contact to other people in order to keep the virus contained. But we're going to talk about settings where this is just not possible because people are living in a congregate setting for various reasons. I have two expert speakers here like to introduce, or they're going to introduce themselves. It's going to be Dr. Alice Kim from Cleveland, Ohio, who's going to talk about the post-acute care setting. And I have Dr. Lee Norman, who's going to talk about his experience in the corrective settings and beyond. So welcome to our speakers. Thank you.
Thank you, Dr. Kurtz. My name is Alice Kim. I work at the Cleveland Clinic. My clinical job is actually infectious disease, and I have also a medical directorship in our medical operations department, where I've been helping with lead the zone state efforts with COVID. And today's talk will just be concentrating on the nursing facilities today.
My name is Lee Norman. I'm a family practice physician, and I am the secretary of the Kansas Department of Health and Environment. So my agency has public health environments, so everything EPA related, Medicaid and the like. As the senior public health officer of the state, I've become quite involved with, of course, the COVID-19 remediation efforts. And I also I'm a colonel in the United States Army, so I've also worked with Air Force and Army troops through the years, including troop movements. So thank you for the invitation today.
Thank you. Yeah, my name's Sebastian Kurtz. Just to finish I have to introduce myself, I guess. I'm a pulmonologist and critical care physician at the Mount Sinai Respiratory Institute in New York. So Alice, do you want to start sharing your insights?
Yes, I'm going to bring up my screen and hopefully I do this correctly. All right, again, I want to thank you, Dr. Kurtz, for the introduction, and for Chest for inviting me to my presentation today. My title is COVID-19 as a Catalyst for Change, and we're focusing on Ohio's congregate living COVID strategy. So preparing for this topic really gave me some time to reflect back on the extraordinary year 2020 was. And really it all began as one of the co-leaders of our incident management team over at the clinic, where we had to be all hands on deck. As you know, we had to rapidly strategize, operationalize, and execute procedures and policies and guidance, not only for the safety of our patients, but also of our caregivers and for our community. And even within the community, we had to really look and see how we were going to partner with our previous rivals within the hospital community, as well as break down silos with our public health partners. And we really had to learn how to intersect paths and work together as the crisis was looming. So today, I'm really just focusing on the team of teams approach that is our culture here at the Cleveland Clinic, and see how we expanded that to our Ohio zone approach, how we then link that into our congregate living strategy, and how we are using geospatial mapping as we move forward. So early on in the pandemic, our governor, as well as our medical director of Ohio Department of Health, Dr. Amy Acton, divided our 88 counties into 3 healthcare zones. So the zones were put under leadership of a commander within a health system. So zone 1 was put under the leadership of my boss, Dr. Robert Wiley, who was the chief of medical operations under the Cleveland Clinic. And he had oversight of regions 1, 2, and 5, as noted in the diagram. Zone 2, which was the middle section of our state, was then led by Ohio State University, and Zone 3 with the Dayton hospitals. And really a way for us to connect experts in the healthcare field to the governor's office and state officials to get the initiatives we needed to get done quickly and fastly as the pandemic was going through our zones. Just to give you some perspective, we have about 190 acute care hospitals in Ohio. additional 50 plus other facilities that do some acute care rehab and psychiatric care, as well as 10 children's hospitals. Since I'm focusing on the nursing home facilities, just going to give you perspective that we have 960 nursing homes within our state. So the Team of Teams approach, we really approached it initially with meetings on the virtual platform. These were both on the zone level and on the local level, led by Dr. Wiley or me as his deputy commander, and really having a multi-sectional sector approach to who participated in the meetings. So on the zone level was really to get all the hospital leadership in the regions that we had oversight on 1, 2, and 5, and those included not only the CMOs, COOs, as well as the directors of their emergency management agencies and directors within their hospital system. We also engaged the regional healthcare coordinators who had local emergency operations control oversight, as well as outreach to our public health partners and our nursing facilities. From the state level, we had members from the Department of Health, the emergency medical agencies and National Guard, and other government officials from city and state. We brought up topics, and we still have these zone meetings 3 times a week to look at national and also state updates, to look at surge reports, outbreaks. And what was really great is we brought guidance and messaging to this group of attendees. And again, because of the rapidity of all the changes that we had with especially masking, PPE, isolation, and resource allocation, it was a great forum for us to get that message through to a lot of people to then message back to their hospital systems. Every time we have a meeting, we have a situational report call from all the hospitals, looking at their operational activities on admissions for COVID and on non-COVID related patients, the occupancy, capacities, and vent utilization. Also have them report out on COVID positivity trends, and also bring about action plans for their surges that, again, need some assistance from our within the zone, as well as spread best practices within our regional leadership. The local meetings were initially occurring daily, mirrored what we were doing on the zone, but now have gone to once weekly, where we actually look at local updates and look at how we can all help with coordinating for throughput and surge and outbreak situations within our Cleveland area. We did a lot of initiatives. This is just a slight bearing of what we did, but again, broken up to what we needed on different levels of care. So on the acute care level was really initially seeing how we can all support each other with load balance and transfers, and then escalate the need for higher level care to those hospital systems that could take those, especially ECMO patients on. We also then had processes in order to look for resource allocations, not only for vents and PPEs, but for pharmaceutical therapeutics, and also looking how we can support each other with surge with a hotline that was made available for anybody to call into if they needed any assistance. So simultaneously, we were looking at the congregate living care situations and seeing how we can support them. And that's what I'll focus on for the rest of this presentation. So with my background in post-acute care for the last decade, I really understood sort of the limitations that they had, not only on sort of the deficiency of sort of clinical support, but also material support. And really, it became a very precarious situation then when COVID-19 came, and it was spreading fast. And we really needed to focus on how we can support them with a safety net. And that was what my focus was. How can we support them with a net of not shouldered by one hospital system or one public health system, but how do we do it partnering with everyone? Because again, it was going to be a big effort. And even though people who, like me, who work in the post-acute knew about this vulnerability, I don't think on a national level, it really became known until the MMWR report that came out in early spring in March. And then it really did highlight how the infection control practices really were not up to speed and caused not only intra-facility, but inter-facility spread of the infection, and how these highly vulnerable patients, because of their age and multiple comorbidities, were really vulnerable to severe illness and from death from this infection. So this report really highlighted the high attack rates. They had up to 2/3 of their residents get infected, with dozens of their staff and even their visitors. 57% of their residents became hospitalized, and I believe another 36% or so of their visitors, and 23 of their patients died. So high case fatality rate for the residents was up to 27%. So again, what we learned from this was that the spread was because staff members were working while they were symptomatic, but also working in multiple facilities. And again, this is not uncommon in the post-acute care setting where these staff members are working at multiple facilities at the same time. So with the infection control and prevention practices, it was not, they were unfamiliar with the practices, and again, were hard to adhere to even the standard practices that they should have been recommended to do. But on top of that, the other layer challenge was that they didn't even have the adequate PPE at that time. And remember, early on, PPE supplies were down, and that did not allow them to, again, do the best practices for infection prevention and control. Early on, there was a delay in the recognition of these cases. And again, as we got to learn that elderly patients did have subtle changes in their behavior and mood that would be sort of the first symptoms that could lead to COVID, be recognized as COVID infection. And again, they didn't have that low index of suspicion early on. And again, the testing availability was not there early, it was limited, and they could not confirm cases as they were coming through. So all those really contributed to the high case fatality and illness rate in those facilities. In addition, I think besides even being in a nursing facility or congregate setting is that, as we know, most of these patients in nursing facilities are older and have underlying medical conditions. So again, higher risk for severe illness. And even in Ohio, by that spring, we realized that more than 50% of the deaths due to COVID were in the elderly. And then when you broke it down even to the long-term nursing home population, almost 80% of their deaths were related to COVID in that environment. So we really had to work proactively and see how we can stem that progression. So the CDC really worked on trying to continue and reinforce infection prevention practices that we had already been implementing for seasonal viruses such as the flu. But on top of that was also giving higher recommendations for visitation restrictions, restrictions of those that personnel that really did not need to be in there, and also understanding how we can do social distancing by canceling group activities and communal dining, and also implement active screening, not only of the residents, but of the healthcare providers that were giving care for these patients. And as you know, that group, the nursing home facilities, were the first to implement these really restrictive visitations that were ultimately in the following weeks taken up by a lot of the acute care hospital systems. For us in Cleveland, again, it was really trying to make sure that we gave the support that the facilities needed to keep their patients on site and monitor them. And it was really the realization that if they sent patients out, again, the infectious risk for that, but also we were very cognizant of the normal route for these patients was that they would be admitted to the hospital immediately for any change of condition. And we could not have that big surge coming into the hospital system. So how could we have them recognize early signs and symptoms, have them isolate them, and order testing as needed? And what we found out is that we needed to help them cohort patients. They really did not understand how the COVID positive patients really needed to be separated from those under investigation. And by giving them sort of the support on the clinical side, by advice and guidance, was also giving them sort of support on the virtual platform. So we did have virtual visits set up for most of the facilities so that they can ask what they needed to do next, and also standardize the criteria for these facilities to know how to assess and then ultimately transfer to the emergency department. And our criteria were then implemented on the state level as well. This all evolved into a formal strategy where we were looking at how we identify patients, facilities, link up communication, collaboration, standardize the care, and then centralize what we're doing with either data and action plans. So initially it was really to identify what the nursing facilities and congregate living situations were, Again, it wasn't just called a nursing facility. There were other different congregate living facilities that we will have to that we definitely need to be aware of. We got listing from the Ohio Department of Health, as well as our regional healthcare coordinators, to understand where they were, who they were, and how they functioned. We linked them up to the acute care hospitals with their networks, and also brought in our community partners in public health, emergency management, and our healthcare coordinators. All this really was because we all felt that this was the beginning of a really big storm, a wave of things that were going to come and ebb and tide as they go. And really, we needed to link them together so they had an anchor of support. So in zone 1, as we look to identify these facilities, and again, I'm just going to concentrate on the nursing facilities, we had over 450. We had in zone 1, 88 acute hospitals, 52 public health departments, and 3 regional coordinators that were scattered within each of the 3 regions within our zone. We linked together the nursing facilities, the local hospitals, and then to regional hospitals, and we designated 3 regional hospitals within each region to be designated leads, and then also identified the public health sectors, as well as emergency management agencies, and then identified the anchors of support for the zone leads, with Cleveland Clinic leading, but also having assistance from the university hospitals and Metro Medical Center. So this all led us to be able to have a clinical and lab network of support. Again, that safety network that I had discussed earlier. And it was really connecting all these nursing facilities to hospital systems to provide not only clinical support, but also lab testing support. So we did find facilities that didn't have any affiliated affiliation with any hospital system. So we did assign them, so nobody was left behind. We honored existing relationships, and then had the extra layer of support of the 3 zone designated hospitals, as I mentioned, as their anchors. The lab affiliations closely followed and mirrored the clinical affiliations, but we did honor existing lab contracts with commercial vendors or referrals, and again, had that extra layer of support with the 3 zone designated hospitals in the labs and hospital systems to, again, take over the overflow labs that could not be supported by their contracted labs. We had the local health departments as the gatekeepers, so they were to assess and the clinical and resource needs at the facility, do what they could, and then tell us what they needed from the regional and zone level to help support their efforts. In addition, we wanted the nursing facilities to be proactive. So we, in April, we had them fill out, we launched a Congregate Living online Red Cap survey that they needed to fill out every week to every month. And it was really for us to make sure that their contacts were updated, so they knew who we knew who they were, and then they knew who their affiliates were. This was another venue for them to also request guidance for clinical and lab resources in a expedited fashion, as well as prevent redundancy. So really, the central directory for all these nursing facilities was really a big foundational support as we moved forward. So with the standardization of the contacts, we also then standardized practice with guidance and management that included not only PPE, infection prevention, but also treatment and strike teams and testing. This also led to us having a standardized process for resource requests and transfer processes. So within the big major health systems, we all had our own playbooks that we pushed out to our affiliates, but then also to the zone. Again, giving the nursing facilities a way for them to have something to look at for not only infection prevention, but also for outbreak control and management. And really, this was sort of like a living document. It was updated very frequently, so they understood when the guidance had changed that they really needed that they had a resource for them at the facilities to use and to train their own staff. Regarding the hospital escalation process, again, we wanted to make sure that we had a streamlined process where facilities were not scrambling to find out where their patients could go to appropriately and safely. So we advised the nursing facilities to, again, do lateral transfers within their local regional referral hospitals, first. If there was a need beyond the clinical need that could be supported within the region and needed escalation into the zone for the clinical need, and or because bed capacity was an issue within the region, it went up to the zone. And what we did is we augmented the transfer services that were already and centers that were already established and put regional physician leads to help assist the transfer centers and the hospital leaderships to expedite transfers, and again, make sure that the patients were getting to the right level of care at the right facilities at the right time. So this is just really a summarization of the progression of support and the standardized approach that we had for not only resources on the clinical, but on the physical needs. Again, we really wanted to support the congregate facilities on the nursing side and have them be proactive, have them be able to identify cases and manage and treat them on site, and really give them the resources to, again, inventory their needs first, which was not only PPE and testing, but also staffing, and that they need to explore their options on the external vendors and agencies first, and then alert their local health departments as soon as an outbreak occurred or when their need was there. That then escalated to the local health departments who identified and coordinated needs. And if they could not support that, was to go to the local regional hospital partnerships, who again help facilitate and coordinate any of the support that was needed at the facility level, and then ultimately go to the zone, where we helped out and worked closely with the Department of Health and Ohio Emergency Management Association agencies for those unmet needs. I have to commend the Ohio Department of Health, because early on they realized that the state needed to support all the zone efforts, and what they established was something called the CURT team. It's a Congregate Care Unified Response Team. It was a multi-agency, multidiscipline team that they formulated to coordinate congregate care living, not only technical support, educational support, but also working closely with the zone leads, health departments, and emergency management agencies. They supported and formed the bridge team, again, helping with not only PPE support, but as testing happened and we were noticing more healthcare workers going out, they were also supporting staffing. So they had a volunteer base that they vetted, a licensee base that they also vetted, and they also had the Ohio National Guard support some of the facilities that had staffing issues, and also helped evacuate facilities where patient safety were at risk. Hand in hand, they also established the healthcare isolation centers, or HCICs, which were existing nursing facilities that were able to apply for additional financial support if they were able to take care of active or recovering COVID patients. So they needed not only to have the staffing support, the resource support, but also sort of the facility layout that was conducive to taking care of these patients. And really the goals were three. It really gave them the facilities that applied for this a way for them to manage the patients on site for themselves. It also gave a venue and facility for those in that level of care who were not able to support those patients to be able to transfer into an HCIC so the appropriate care could be done, and also help the acute hospital systems. So instead of, again, admitting patients who did not need that level of care into acute hospitals, they could go to these HCICs, and then also help with the efficiency of throughput at the acute hospital level, where we could transfer these patients at the time of discharge to these facilities that we knew could take care of these patients that were either actively with COVID or convalescing. All this framework is really important, as we understood that, again, the population in these facilities were not getting infected from symptomatic healthcare workers, but also from the asymptomatic carriage within the community. So by May, there was a directive from ODH that we needed to start doing facility staff testing. And again, having that infrastructure already in place really helped with this coordinated effort. So again, I'm working with the Ohio Department of Health, and then having our own clinical zone lab and clinical affiliations were all very helpful and needed as we got the Ohio National Guard to start to swab, as well as get the local health department to do the monitoring. So within a 6 to 8 week period, we were able to test 900 facilities, 68,000 or more employees, and 1,700 residents in a very coordinated, seamless fashion. Again, they took our lead from zone 1 and pushed out how we coordinated logistically to the other 2 zones in the state. So we are still working on our active efforts of COVID in our state. Again, we had 3 surges that have mirrored what happened nationally. And again, looking back, it was really issues with PPE in the beginning, testing in the middle, and then really acuity of hospitalizations in the end of the year. We are still having long-term care facility cases, as you can see, with still a high mortality rate, with about 50% of our cases of deaths still being represented in the long-term care facilities. So hopefully, hoping that with continued efforts, we can get through this pandemic together with better numbers to show. The last thing I'm going to concentrate on is the centralization of mostly with data and efforts, looking at how we did reporting and the directory, and also looking how that helps solidify action plans, and also then touch base about the geospatial mapping that we're doing with our analytics department at the clinic and beyond. So as most states and local health departments have had to do is look at how centralized monitoring and reporting of the cases really did help identify outbreaks and then help with action planning. And that also was augmented in our zone with how we had a directory of contacts and resource needs and allocations that all helped really coordinate intercept teams when outbreaks were actively occurring, and also centralizing the transfer process for patients who needed higher level of care, as well as coordinated efforts with resource allocation and distribution. I have a shout out to our team in the business intelligence at the Cleveland Clinic, Enterprise Analytics. They've done a huge effort with how, with over 150 plus metrics that they've put in dashboards for us on the enterprise level to help us understand and again, move forward with COVID planning. The one thing that I'm going to concentrate on is their role in regional surveillance, where they have used their data analytics to help us with cluster identifications of new COVID outbreaks, and then we can help focus interventions and contact tracing at those sites. So there has been a lot of predictive modeling. It's beyond the scope of this presentation, but again, geospatial mapping has been done with collaboration, not only with our team, but with Case Western Reserve Curtis Lab and the University Hospitals of Cleveland. And it's really been an innovative way for the great minds in Northeast Ohio to collaborate on COVID efforts, identify cases, so that there's awareness not only within our hospital system, but within our community for our public health partners, so they can do, again, targeted intercepts and action plans efficiently and timely, so we can control the outbreaks that are happening within our community. So the first thing was really to look at how we congregate housing locations where some of the cases were happening, but it really helps us focus not only on that particular congregate living, but also what is the activity around in that neighborhood. So again, we can focus interventions. The other thing that we can do is look at different variables. For this one in particular, in the right-hand corner is looking at the higher vulnerable patients that are elderly, and how many within that area of an outbreak were those, so that again, we can target interventions. They have been doing heat mapping also based on the zip codes, again, to help our public health partners understand where outbreaks are occurring and where they need to concentrate their public health efforts. And the next layer is really looking at socioeconomically challenged areas, not only in the neighborhood, but in a regional surveillance area. So again, community efforts can be targeted to these most vulnerable areas and get resources to them quickly and efficiently. This is my last slide. I am an eternal optimist. I know lots of things have come out of COVID. The cases, the illnesses, and the deaths are, almost too much hard to believe. But the one thing I do want to commend is really the partnerships that have evolved throughout our region, and really everybody taking sort of the recognition and the obligation and the responsibility of healthcare systems, that we really need to be sharing our resources, not only physical resources, but our knowledge resource to those beyond our hospital system into the community. So again, that we can have again, a foundation to help us move into a better, hopeful future. And again, a lot of these efforts that we implemented are now helping with our vaccine strategy in the state and in the region. So thank you. And that's my presentation.
Thank you so much, Alice. It was great. And I think probably a lot of people who are watching this are just astonished how much planning and on a what's, which kind of scale and professional planning this occurs. Now, my first question in this regard, did you guys have a blueprint? Or did this all develop from scratch?
Most of it developed from scratch. So a lot of the strategy was me and a few other members, again, trying to operationalize and get things executed as soon as possible. So I did have sort of the mentorship of Dr. Wiley, who has been in incident command and helped with the other outbreaks. But essentially, it was not to the scale or the longevity and the multiple crisis issues that occurred throughout the year. So a lot of it was just trying to get people connected and understanding that we needed to all be on each other's shoulders and helping each other out from many different healthcare delivery sectors to get things done.
And I think the Midwest was kind of hit a little bit second in line, right? I think the very first cases we saw on the West Coast, and then the East Coast got really hit hard. Was this an opportunity for you guys to kind of see what may be coming and essentially get your strategy together?
I think we were all aware of what was happening, especially on the East Coast in New York City. And the one thing that Cleveland Clinic did, and probably some of your colleagues, now that I know that you trained here, was that we did send a group up there of healthcare providers from the, nursing all the way up to physician level to help out with those situations. And they did report back to us about the conditions and what they saw. So we did implement some of those, looking at best practices and how we could make those even better practices on the enterprise, and how we push that out into the region.
That's great. Yes, we were very grateful for all the helping hand coming from Ohio and from all the other places from the United States. So yes, we here in New York, we really got hit hard, and we have seen a healthcare system essentially at the breaking point and beyond the breaking point. Do you feel like this was, and what was there a point when you felt you guys may be having the same problem, that you may be able to handle it, or did everything a big scheme work out for you guys that you were able to handle it?
I think with Dr. Wiley's leadership and really making sure that everybody was part of the team, we really wanted to be the support. We wanted to share our resources. That was very visible and transparent early on. So we knew by predictive modeling that these surges were coming. They didn't come as bad as we thought. I mean, I think our regional predictive models were about 10,000 admissions a day. Thank goodness we never got there, but we were prepared to do it. And again, although we were leading the efforts because we have the resources at the clinic, not only with beds, but also with physical resources and personnel, it was really getting everybody else on board to contribute as well. And it's been incredible to see, again, the partnerships that have happened. And again, nobody can do this on their own. We are all being affected. And that was the one thing, I think, the transparency of what we were trying to accomplish here was partnership and collaboration. And that's the only way that we knew that we were going to get through this. Now,
it sounds like you have a blueprint now for any future kind of epidemic that may be coming. Are there serious efforts to kind of to keep some of the core structures in place, or then they have the manual ready, let's say optimistically, when this epidemic is gone, be prepared for whatever may become in the future?
Yeah, I think this is a framework that we were thinking will be the foundation for everything coming forward. We know there's going to be probably another pandemic. And again, having this infrastructure of network support is something that we need, and we're still building it. So there are, again, vulnerable populations in the group homes, homeless shelters and stuff that we are still trying to outreach to. And again, with the foundation we have, it was very helpful and is being helpful on how we're launching vaccination efforts currently too. So yeah, I hope this is the foundation. I hope we keep the partnerships because I think it will be necessary in the years to come.
Great, thanks again. Dr. Norman, do you want to share your experience in a slightly different setting?
Sure. Yeah, thank you. And it's a dramatically different setting. By the way, in my background, I've been a chief medical officer for 26 years, half of that up at Swedish Health System in Seattle, Washington, and the other half at University of Kansas Health System in Kansas City. So I've always been a hospital guy, and one of the things I was very concerned about early on, as per Dr. Kim, was keeping from overrunning our hospitals also. Yes, care about people that are incarcerated, but we also, because that's a very labor-intensive thing when people leave correctional facilities and go to hospitals, it causes all sorts of social and other kinds of dynamics. Let me start off with a general discussion. I've got a few slides to share, and then we'll be able to answer questions. I'm not an expert on the prison system and corrections, but by necessity, my department, as the secretary of the Department of Health, and I'm also the state health officer, so I'm the senior health official in the state. Much as we saw in nursing facilities, we saw some of the same explosion in terms of the number of cases that were occurring in correctional facilities. Correctional facilities are not a homogeneous group. We have the Department of Corrections that are run by the state, and then the county jails and retention centers are run by the county. Counties, plural. We have 105 counties, each of which has its own jail, and we don't have our command and control there, but we do in the state Department of Corrections. That doesn't include the federal penitentiaries like at Fort Leavenworth and so forth. And yet, the thought that offenders are placed in one facility for a long period of time is just not reality. I've learned that there's a tremendous amount of churn, people coming and going into work programs, coming and going from the community into a jail and then into a prison. And so to think that it's a stationary group of people that are confined to one area is a faulty way to think. And just look at the communities that house correctional facilities, and you'll see that staff people come and go, offenders have work release programs, and call it what it is, prisoners are cheap labor. Great example, when the state fair of Kansas, which is, mom and apple pie and livestock shows and everything else, it's in the early fall in Kansas. They were, the state fair board was determined to have the state fair. And it wasn't until we said, that's fine, but you can not have prisoners on work release programs at $1.80 an hour or whatever it is that they are paid, then that's what killed the state fair. It didn't end up being the state fair board, but it ended up being the economics of restricting prisoners to not be able to participate because of the infectious disease spread. And of course, by this time it was into August and September when we were deep into this pandemic. So I am going to share a screen here. One of the things that I want to talk about is how do we care for prisoners or offenders in congregate settings? And one of the things that we did was, because nobody wants to, the public doesn't really want to devote resources to prisoners. So when we go back and look at, as per Dr. Kim said it very well, the shortages in PPE, testing, case investigators, contact tracing, hospital capacity, staffing, antibodies, and vaccine. The general public, and it's kind of a dark side of this, of our general public, I think, really don't want to allocate those to offenders that are in prisons. And I've had it at legislative hearings, questions brought to me as straightforward as So wait a minute, Dr. Norman, you are saying that you would prioritize a child rapist ahead of a 68-year-old grandma or a 64-year-old grandma. And so we always have to come back to what we consider to be why and how did we get here? And as you can see, the thing that has guided us, and again, we just didn't make this up. Department of Homeland Security, CDC, and others said, well, number one, what's the likelihood of clinical outcomes being bad and death? For Dr. Kim, nursing facility, long-term care are at very high risk of that. Offenders in prisons are too. Proximity. Our residents and staff in close approximation to each other. And residents, yes, and offenders have bunkmates. They've got bunk beds in their very small, 5 feet by 5 feet cells, some of them. Type of contact, is there continuous exposure to droplets, shared surfaces, and the like? And the answer, of course, is yes. They're in very close contact with each other. Contact duration, average of interactions last more than 10 minutes. The people don't have anywhere to go in prison situations as in incarceration. They don't measure it in minutes. Oftentimes they'll measure it in months to years. And then finally, the challenges to implement protective measures. Space is indoors, confined, and not possible to control with whom workers will interact. I can assure you that prisons were not built with COVID-19 in mind because people are literally on top of each other. So you talk about an ideal situation for spread of a highly infectious disease, and this is what it is. I might add that the prison population is not a homogeneous population. It is very heterogeneous. You have everything from people with lymphomas and leukemias and solid tumors, and there's a lot of medical illnesses in the offender population. One of the first things I did was to say who in our agency knows anything about this. And fortunately, I had a couple of people, one in particular, an epidemiologist who for 20 years has worked with tuberculosis, hepatitis C especially, and HIV in prison populations. And it wasn't that it was an experience in the illnesses specifically per se, but he knew prisons and how prisons work. Okay. So therefore, with those criteria I mentioned earlier, this is what we call congregate settings. And this is just from our website. We have that very well defined, and prison population is one of them. So we've made it through the first phase of our vaccine program. And now we've moved into the phase 2, which is a very large group. It's about a third of the Kansas population. And included in phase 2 is prison population. And by the way, and people might not admit it over the dinner table at night, but people don't want to use vaccine on prison population. That's just not a popular thing to do. So I have this one and then one more slide, but they're pretty dense and I just want to talk through it. What did we really learn through this? Because we've been in incident command now for over a year, 54 weeks to be exact tomorrow. And because we saw this, starting to materialize and knew there's going to be a problem. So one of the things we did very early on was to limit visitation and programs, some of which were programs to leave, that like work release programs and the like. Very unpopular thing to do. Matter of fact, I've been sued personally, as my agency has too, by various offender rights advocacy groups and the like. But we put a clamp down very quickly on visitation and programming. We did and prisons are, correctional facilities broadly are everything from 120-year-old facilities all the way through new sparkling facilities and all points between. So when I talk about number 2, applying anti-contagion measures, mask surface cleaning, et cetera, those are pretty straightforward. Social distancing is very difficult. Some of the newer correctional facilities do allow for social distancing and cohorting of patients, which will become important in a minute. Some look like they're almost gulags, from a distant past in terms of just the physical appearance and the functionality. Symptom screening of staff and anyone coming and going, even with no apparent cases in a facility. The COVID-19 doesn't crop up in the offender population as long as they're not coming and going from the facility. It comes from the staff, and staff are hard to control, as you can well imagine. So we put in symptom screening early, and then later on, and I'll make this point in a minute, added in testing. Well, now it's the next point, active surveillance of staff and offenders. We particularly focused initially because of the shortages on the testing. To do standard PCR testing on symptomatic offenders, what we basically put out as a rule very early on was anybody that's symptomatic needs to be tested with the same day turnaround on stat PCR testing. And eventually, even though antigen testing isn't as desirable, if we have also migrated to include regular Abbott ID Now screening of asymptomatic offenders as well. And we've picked up a lot of things early on. We've had whole units that we've tested that have been as high as 70 or 80% of the offenders population at one time on fairly large units. Immediate quarantine and isolation of infected offenders and testing of all contacts at baseline and every 7 days until the quarantine cohort are all negative after 2 weeks. That may sound easy to test and quarantine, but it is not. And it takes a lot of movement of the incarcerated individuals from one prison to the next because of facility limitations. It's not like there's extra prisons that you can just pull online and say, good, there we go, that's a COVID prison. Not quite so easy as that. Identified best isolation conditions in that KDOC is Kansas Department of Corrections, including ventilation and HVAC, and moving infected offenders when appropriate. Some of the older prisons have essentially, I spelled ventilation wrong. Some of the older ones don't really have ventilation systems. They have very, very rudimentary heating systems. Some of the more modern ones have single prisoners or single incarcerated individual cells each with its own HVAC. So we quickly found out that one of the prisons in Lansing, Kansas, was the place where we really needed to move the infected offenders to keep them from spreading to others. But again, when you move 60 to 80 patients or offenders at a time, that has its own series of challenges. Setting up COVID management units at facilities that are near acute care hospitals. A COVID management unit is essentially a small prison, a small hospital unit within a prison, and have those near acute care hospitals. So it was pre-positioning people that are at high risk of becoming ill that were known to be infected. Establishing rapid direct admission criteria jointly with hospitals, including direct priority transport with EMS. One of the things that we didn't want to do for either the accepting hospital or for the correctional facility that was transferring the patient, we didn't want to have to go through a series of 99 questions on either end, but just to say, as per number 9, have you met the criteria, the trigger criteria for patient transfer? And if the answer is yes, then it's okay, send your patient. And then to have EMS already lined up to do so. So, you know, hospitals are, and I'll say it because I know I've been a chief medical officer in the hospital for a very long time. It's a hassle when you have prisoners in the hospital because you have a lot of extra police and whatnot. And EMS is not too crazy about it either. So it's better just to pre-wire everything to be done. And then finally, upon containment, regular staff surveillance, including asymptomatic staff. We're typically able to snuff out in any particular correctional facility through the things I've talked about in 1 through 9 above, but you can't blink. And the reason is because it's going to come in again. So we found early on that we had to continue to screen asymptomatic staff and, of course, to not allow symptomatic persons to come in. A few discussion points. This one has led to a few scars on my back. Ethical considerations about prioritizing incarcerated persons over others. The general public doesn't like to do this. They would rather have prisoners be out of sight, out of mind. I did like to point out that prisoners are constitutionally defined as wards of the state, much like foster children are. And so it's not like it's without legal basis for the taking care of incarcerated individuals. Another point that's interesting is the COVID variants B117, the 1351, and now B1 from Brazil. We are doing a lot of genomic surveillance in the prisons. We have one prison right now. I'll find out ideally the results later today of one correctional facility that has had no cases for a few weeks. And then in just a blink of an eye, 36 hours, there's 50 cases. And that's faster than what we normally see of spread. So we're a little concerned that one of these faster spreading variants might be coming. We curiously, through our hundreds of thousands of genomic surveillance testing we've done, we've not found those variants yet in the state of Kansas. I'm sure they're here. Another one that is that a lot of states, Kansas being one, doesn't have enough correctional facilities for all those that are incarcerated, so they get farmed out to other states. And yet other states, you're never sure how do they manage their folks. And yet when enough beds open up, we'll say, enough cell space opens up, they get sent back to the states. One of the things we've done is have gone to those states that have been on a contract basis, taking care of our offenders. We will set up testing at our expense so that we know that they're not going to bring them back. There was one situation, I won't mention the state where they were housed, but of the, I'll say 150 offenders that were coming back in one cohort, all of them were infected. And it was mostly asymptomatic. Department of Corrections, the state managed. We have pretty good control over. The county jails are not within the Department of Corrections. And to that end, we've seen whole sheriff's departments who were shut down because of COVID, because they took, especially out in western Kansas, it's kind of the Wild West out there, don't necessarily embody all the principles we talk about. So some of those, not only did the jail, the offenders get infected, but so did the police stations, or in this case, sheriff's office. Discussion, what do the prison staff do at their time off? They do things like everybody else, and they bring in the virus. So we looked at every single staff person as somebody that was possibly bringing the virus, of course, into the prisons. That's not unlike nursing facilities and long-term care, I realize. We got to number 17, public safety considerations with staff shortages. We got to a point, and I saw this in hospitals as well with hospital staff, where there were so many people that were either infected and isolated therefore, or quarantined, that it became in hospitals, it becomes an issue of just how do you get the work done. But in prisons, it's a matter of public safety and how much absenteeism can you have and still have a safe environment for the staff and the inmates. And finally, you can't turn a blind eye to the unions. The correctional officers are pretty much all represented by a union, and they have an intense concern for staff safety and their own pressures to bear. So in summary, the correctional facilities have their own nuances. It's tightly interwoven with the ethics of taking care of prisoners. And then, of course, the logistics are completely different than in a free living population of people. So with that, I will turn it back to you, sir.
Oh, thank you very much. I think that was very insightful about a real problem, which I think many people don't think too much about. And I think I wholeheartedly agreed that, I think the state has an obligation towards these inmates to try to protect and take care of their safety. Now, one question is, and that's probably different to the nursing homes, correction staff, workers in the correctional facility, they're not medically trained. They don't have a background at all. Especially at the beginning, did you guys have problems really with people, number one, they may just be completely uncomfortable going into that a potentially infectious environment, or don't know how to use protective equipment. And to start with, how real were the concern that they didn't have actually the tools and equipment they needed to do that job safely?
Yes, good question. There is in each correctional facility, there is a clinic that are medically trained individuals. It's mostly by nurses or nurse practitioners or PAs with an overarching medical director, someplace not necessarily on site. But I'll tell you, a lot of our infected staff were the medical staff and nursing staff. Was a real hotbed. But you're absolutely right. They were not necessarily what I would consider on the cutting edge of acute care expertise that were the ones caring for now these becoming complicated patients. The other thing is, a lot of the people that are incarcerated are not particularly cooperative or follow the same social norms that the rest of us do. So, and they have the right to refuse testing, for example. And so there's nothing easy about it. And there had to be, we had to get a little bit into this before the offender population, a lot of them said, I guess this is serious after all, isn't it? Because they'd see a few of their people ship out to go to hospitals, and of course, some don't come back. We got better buy-in once there got to be more of a groundswell of that visible illness. It was a shame to see it come to that, but the offender population eventually kind of became more likely to rally around it. But you're right, especially when we had shortages of everything, it was really a matter, call it what it is, rationing of those things in a particular correctional facility. Fortunately, we've gotten beyond that now. I had a lot, as I mentioned, I'm a colonel in the Army and in the Kansas National Guard. And fortunately, I have access to Guard personnel that maybe others didn't. We had at one time 780 people, airmen and Army soldiers, many of whom we dispatched to the correctional facilities, because when you show up in fatigues in combat attire, then people suddenly become more cooperative. So that ended up being a pivotal in helping us to get the correctional facilities under control.
And I think now, fortunately, we're looking like we are getting around further with vaccine distribution. So, and you mentioned a challenge to kind of advocate for getting enough vaccines for the inmates and, of course, the staff. How is it being taken up by the staff and the inmates? Or are there any concerns about, well, this is experimental drugs, and of course, it's a vulnerable population. We're finishing that.
We haven't started immunizing the offender population yet.
Okay.
But we have the staff, and particularly the medical personnel. The medical personnel were in phase 1, along with hospital and other kinds of medical personnel. The staff have been readily accepting it, readily meaning, as Dr. Kim and you and I were talking about before we started, around maybe 65%, 70% acceptance rate. We haven't gotten enough vaccine into the state yet to start administering to the offender population. We'll see. And
another question is, you mentioned the challenge with the asymptomatic carrier, and being in a hospital, it was exactly right what you mentioned. Even if you were considered in contact at times, as long as you don't have symptoms, you are obliged to show up for work. Now, could this setting be used to get some more epidemiological insight about what is actually the carrier rate and what the infective risk of these asymptomatic carriers? Could we learn something from that setting, and are there resources to do that?
Yes and no. Yes, we can learn something, and are there resources? Not yet. We've taken copious notes, and one of these days we'll surface on the other end and hopefully understand. But I'll tell you what, it's in a wing of, let's say, 120 incarcerated individuals who are basically looking okay, and you then do deep nasopharyngeal PCRs and end up with 75% positivity rate. You say, oh my gosh, how did we get here? And it was all because there was one person that became infected. So the contagiousness of this in that kind of setting, and I described the physical setting, it just boggles the mind how highly infectious. And again, we haven't found any of these highly infectious ones. The old ones have not.
Right. Focus a couple of questions we got to the beginning of the webinar. There was one question about a problem that a large fraction of the skilled nursing facility staff is hesitant to get the vaccine. How do you get around that? I'm not sure if either of you has more personal experience with workers, and is that an issue that has come up actually? Just wondering if you have any.
Dr. Kim, you want to take a whack at that?
Sure, I'll whack it out. No, I think it became clear there was a lot of cultural issues, racial sort of hesitancy that we knew within the community and within the nation that we were going to have to deal with. So a lot of the things was really trying to message to them. There are local efforts through the public health departments, but also at the facility level to get them to understand from either nursing leadership, their peers, mostly physicians, that it is a safe thing to do. And even with that messaging, it was a slow uptake at first, but as we've gotten the first round of vaccines out and the second doses out, and they are seeing that people are actually doing okay with it, and there's more advocacy within, the healthcare community and abroad, that the uptake has really swung high. I mean, it was normal initially, lows in the 20s to 40s as it was rolling out 40%, and now it's up to 80% plus. So I think we'll get there, but a lot of messaging and reinforcement has been key. And understanding that it's not only protecting them, it's also protecting their patients. So I think they have that in their heart too, that it's not only for them, it's for the people that they're taking care of.
And really, Dr. Kurz, I would say the same thing is true on the correctional facility side.
Yeah. Another question came up, and I think it does concern staff safety. The questions are any standards how people can safely have a break in terms of to minimize airborne transmission. I know, of course, in the hospital that came up that only a limited amount of people are allowed in a break room. There has to be adequate ventilation and things like that. Is this a concern that can also be addressed, let's say, in correction facilities, or comes back to staff safety?
Yeah, it is a scheduling, I won't say nightmare, but consideration that to have people take their breaks at a different time, to alter their schedules. A lot of work programs in the prisons have to be changed. And again, some of the folks, a lot of the correctional, the incarcerated individuals are not necessarily ones who like to be messed with. And so we see it's a little bit of a negotiation process. But there was, I would say, fair cooperation with that. But it's limited by the facilities so often in the ability to do that. It's not like you have too many choices when you're talking about a correctional facility.
Got it. All right. So I think we are on the hour. So thank you very much for a very insightful conversation presentation. Again, I think it's a topic where we learn a lot, which we didn't know about before, what there is about to learn. And I just hope for all of us that we continue to learn from these experiences and all these planning that's being laid out, and hopefully have it in place and make use for the future. All right. Thank you very much, both of you, and thanks to the audience.
Thank you.